Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Expert Perspectives in GEPNETs 2024 is the name of our program. We're honored to be joined by Dr. Jennifer Chan, Dr. Daniel Halpern, and Dr. Pamela Kuntz. And why don't you guys introduce yourselves? Dr. Chan, would you like to go first?
Hi, I'm Jennifer Chan. I'm a medical oncologist at Dana-Farber Cancer Institute and Harvard Medical School.
Great. And Dr. Halpern?
Yeah, hi everyone. I'm Dan Halpern. I'm also a medical oncologist at Winship Cancer Institute at Emory.
Great. And last but not least, Dr. Kuntz.
Great. Hi, my name is Pamela Kuntz, and I'm a medical oncologist at Yale Cancer Center and Yale School of Medicine.
So the podcast topic is individualizing therapy for patients with advanced GEPNETs. One of the things that we started with was, how does the choice of systemic therapy, surgery, or liver-directed therapy for individual patients often benefit from a multidisciplinary team? So how does, that we like to sort of understand that as an angle in individualizing therapy. But Dr. Kuntz, would you like to start with this one?
Sure, happy to. So I think that this idea of multidisciplinary care is really, it's critical in cancer care, but especially I think as it relates to patients with neuroendocrine tumors, just because they touch potentially so many different specialties. And I think that many of us have tumor boards that can help really think about multidisciplinary care, whether it's medical oncology, surgical oncology, interventional oncology, nuclear medicine. And it's really at these multi-D tumor boards that we help make some of these treatment decisions as a team. And so I think that that's a really critical takeaway. And then it's really tailoring treatment to an individual patient, where we take into consideration all of the different unique individual characteristics that we talked about, whether it be patient-specific characteristics like medical comorbidities, or tumor-specific characteristics like we talked about in terms of the grade and differentiation. And then it's also thinking about the treatment characteristics. What side effects may they have, and how do those interact with the patient? So it is a complicated calculation, and I think that it really does require multidisciplinary input.
Yeah, thank you. In terms of the particular therapies from the medical oncology perspective, are there ways to personalize even something that's fairly standard, like SSAs, and how you deliver those? And are there ways to personalize systemic therapy with PRRT? How do we sort of think about individualization with what's available?
Yeah, I guess I would think about this in a couple of dimensions. I mean, one would be, how do we personalize the selection of a specific agent versus another for a patient? And I guess the other would be, how do we think about adjusting how we might manage a given agent, given a patient's preferences? I will admit, as I think my colleagues know, that I tend to hew pretty closely to the evidence as best I can, and so I'm a little bit hesitant to hyper-personalize outside of the bounds of the way things have been studied with any particular agent, although of course dose adjustments for adverse events and quality of life are a critical component of that, and I'm by no means trying to minimize that degree of personalization. I think otherwise, really with any particular agent per se, we're probably thinking more about how we can safely navigate follow-up and bring things as close and convenient to the patient as we possibly can, while managing things like the surveillance and reevaluation of the disease. I think though, where it really tends to get complicated and interesting is not just the medical micromanagement of the classic scenario where a patient has hypertension or diabetes and you're picking between an mTOR inhibitor and a VEGF inhibitor. But in that space where we think about perhaps more local regional or episodic therapies, even PRRT can be sort of an episodic approach versus continuous exposure to something. And I do find in my practice frequently thinking out loud with patients and sharing decisions around sort of playing those cards and making those decisions based around activities that are going on in people's lives, and thinking about how do we do this in a way that will have you feeling as well as possible for your trip to Europe or across the Midwest or your daughter's wedding, and avoid having you, as best we can, taking one of our carefully titrated poisons at a time that it's really important that you be at your absolute healthiest. And so those, I think, are some of the critical decisions that we make with folks as we think through what we're going to do when, to help them live not just as long but as well as possible.
Wow, thank you. Dr. Chan, how do you think about sort of individualization, individualized therapy for patients with advanced GEPNETs?
Many of the important factors about individualization of care have already been mentioned. I agree completely with Dr. Halperin that shared decision-making with patients is important and is an optimal way to individualize care. We have to think together about what we're trying to achieve with therapy, so trying to establish the goals of treatment from the outset and as the disease evolves over time is really important. As we establish goals, it's also really important to understand how patients are impacted by their disease. Some patients with low volume and indolent non-functional neuroendocrine tumors may experience no impact of their disease. And in these cases, it's really important to maintain and maximize quality of life. So this is where we may tend to select treatments that have minimal side effects, for example, somatostatin analogs. On the flip side, for patients who have a higher burden of disease or more symptoms, our goals are not necessarily to just control growth and slow progression, but we may perhaps also aim to achieve an objective response and reduction in disease burden that can translate into improved symptoms. Knowing this and setting our goals helps us to select certain treatments that may have a higher chance of response, such as chemotherapy, or in some cases, peptide receptor radionuclide therapy or liver-directed therapy. So working with patients to understand their disease and impact of their disease and what we're trying to achieve with treatment are really important ways to individualize therapy.
Yeah, I think there's a lot to chew on. So really appreciate all of your time, but really enjoyed it, and just honored to hear how you guys are thinking about this and how you go about your practice day to day, given the information that comes out at a rapid pace. So it's an honor.